encourage people.
Welcome, everybody. I think we'll go ahead and get started with some introductions, and then we'll get going. My name is Lindsay King-Cooney. I'm the Community and Tribal Engagement Specialist here at NACC. And Dr. Robbie.
Hi, I'm Kari Robbie. I'm a family practice and addiction medicine physician, and I work with our MAT patients here at NACC as well.
Now we're missing two of our members, Michelle Corcoran, who may join us later. She's our MAT nurse manager, and then Nikki Jardina is our infectious disease nurse. And then we also have Tina Monje, who is our harm reduction supervisor and is also our co-presenter for today. And then we are missing our elder who couldn't be here today, Kevin Smokey Day. So we'll get started with some announcements. I'm going to share my screen. All right, so welcome to Midwest Tribal Echo. Today we have James Schmidt, our harm reduction health educator, and then, like I said, Tina Monje, our harm reduction supervisor and Echo member, and they're going to be talking with us today about harm reduction 101. Oops. So a little bit about the Native American Community Clinic. We were established in 2003. We're a federally qualified health center. We're located in the heart of South Minneapolis in the urban indigenous community right on Franklin Avenue. This is a list of a wide variety of services that we offer from primary care, social service support, behavioral health, and harm reduction services. This is a list of our current open positions at NACC. If you go to our website there, you can read more about each of these positions. And then some session guidelines. Please, no protected health information. If you could mute yourself if you're not speaking. And we do encourage you to turn on your camera if you're able to. That would be great. And we love to see your faces. Please let us know who you are in the chat function, your name, title, organization, and email address. And then that way I can email out any information and also our survey for your feedback. Upcoming echoes. So our next echo session will be June 21st with Linda Black Elk, and she's going to be talking to us about traditional medicines. And then this is a conference coming up in a few weeks. It's Our Nations, Our Journeys, and it's put on by 7 Directions from the University of Washington. And our ECHO team will be there hosting education sessions on MAT programming and naloxone training. And Dr. Stately is also a keynote speaker at this. So if you want more information on that, please let me know. This is a list of our other echoes that we recommend that cover similar topics on OUD, Hennepin Healthcare, Indian Country Echo, and Stratus Health. And then we do offer continuing education credits for these sessions. So it's really important if you can put your email address in the chat, I can send you the survey, which you'll need to fill out for those. And then finally, case presentations. We encourage, if you have a case presentation, please let me know. My email address is at the bottom there. It's a great way for us to have great discussion. And then with that, I will hand it over to Tina and James.
Thanks, Lindsay. Let me just situate here. Let me pull up our slides. Can someone just let me know if you see my screen?
Yep,
I can see it.
Okay. And now I have to figure out where my presentation mode button went. There it is. Oh, where'd it go? Oh, I was in presentation mode. Sorry. Okay. So yeah, thanks for the introduction, Lindsay. My name is Tina Monje, and James is on if you want to introduce yourself quick.
Hello, I'm James Schmidt.
And so we are going to be talking about harm reduction today. Some of it's going to like be really like a back to basics kind of thing. So sorry if this is boring or kind of not quite your speed. I'm just trying to look for my notes right now too. Sorry, guys. I can't talk without my notes. Okay, I'm sorry. I have to stop sharing because I can't find my notes button.
No worries.
Can't do the notes view when you're presenting on the Echo, so I wonder,
Oh, I can't? Oh, bummer.
if somebody else could do that. Like James could run the slides view, and you could have the other view, something like that.
Oh, sure. Or maybe, Lindsay, can you share?
I don't know. I'm
Do
doing
you, yeah, let me see if I can
You should have
I'm fine.
access.
in the
To the present-
PowerPoint.
Yeah, it's in Teams in our harm reduction team.
Okay. One moment.
Sorry, everyone. I thought that the notes could be shown. It's just in there called Harm Reduction 101, Lindsay. James and Tina, I think.
Okay, we're getting close. Okay, I'm gonna share my screen.
Cool.
Thanks, everybody.
Yeah, thank you. Sorry about this.
You see it now?
Yay!
Yay.
Yay. And now I get to have my notes. Great. So yeah, next slide. So yeah, again, as I said, some of this is going to be a super back to basics thing, so bear with me. And I also encourage everyone, if you want to contribute to any of this, if you have any thoughts and any questions, you can just put things in the chat. And then hopefully at the end, we'll have some time for questions and discussion. So first things first, just kind of defining harm reduction. So when we think about like lowercase harm reduction, we're referring to a set of health interventions and an approach to providing services. I think that reducing and avoiding harm is usually a pretty natural and automatic activity that we all want to participate in. And we see it in so many other activities that we participate in life. I don't want the phrase harm reduction necessarily to be co-opted by other activities, but we can look at some other analogous examples like driving. We use seatbelts, airbags, and then best practices obviously are taught widely and people are encouraged to learn about it. Exercise to keep ourselves healthy. We drink water, wearing a knee brace, learning posture, practicing anything. Of course, living with a chronic illness. I know, like, an example I think that Dr. Robbie uses a lot is that when we're working with people with diabetes, we don't withhold medication and you know, tell them to change their eating habits before we give them medication. So I like that example. Shifting habits to individual and unique needs is also an approach to that. The use of drugs in medicine to mitigate pain and discomfort and treat illnesses. And of course, using drugs and learning how to do so in a way that prevents illness and or death. So, you know, the specific interventions used across harm reduction service providers include things like syringe access, and doing it in a low barrier way, which means not requiring personally identifying information in order to receive those supplies. And also avoiding the 1-for-1 syringe exchange method, which is basically people come in, they're required to return a used syringe in order to get a new one. So that is not a recommended health intervention in harm reduction. And some of these things also include syringe disposal and cleanup and other tools for safer drug use, like sterile water, cottons to filter their drugs, drug checking and testing, smoking supplies, overdose reversal medications, medication first and housing first approaches, pharmacy access, supervised consumption sites, drop-in centers, and referrals to non-judgmental care. I'm sure lots of other things maybe that I missed there as well. And so we believe that this approach fosters trusting relationships between service providers and people who do use drugs. And it's not just about handing out syringes, it's about creating mutually respectful relationships so that people can continue to remain connected to others, to other people, and especially to care. And so when we think about the uppercase harm reduction, we're referring to a philosophical and political movement that has grown out of and in response to the history of stigma and racism around drug use, which we're gonna kind of get into a little bit later. And so throughout this presentation, we're both gonna go through the principles of harm reduction as they've been laid out by the National Harm Reduction Coalition. We'll go through those principles and just kind of like discuss them a little bit and expound on them. I'll go for a little bit and then I'll hand it off to James. So next slide. So the first principle, one of them says, accepts for better or worse that licit and illicit drug use is part of our world and chooses to work to minimize its harmful effects rather than simply ignore or condemn them. So obviously, drugs and alcohol have been around for a really, really long time. There's evidence of that and evidence that they've existed since pre-agricultural age. The demand for drugs in the US has remained constant, and it's despite the United States' enormous financial commitment to fighting the war on drugs with well-equipped drug task forces and full force of mass incarceration. Next slide. So this is a fun image that James found that just kind of shows how old drugs and alcohol have been. It's such a, I mean, it just has been a part of humans as an existence. And then the next slide, Lindsay. And so I think that when we're able to acknowledge that people have always and will always use drugs, and when we're able to choose to focus on minimizing harm and meeting people where they're at, rather than creating unrealistic and draconian expectations, we're so much better able to help people. And harm reduction approaches are, widely proven now to work across the board. For instance, people are 5 times more likely to enter substance use treatment when they are able to access syringe exchange. And the next slide. Another principle says, does not attempt to minimize or ignore the real and tragic danger that can be associated with illicit drug use. And so we see these harms on a large scale, societally, and then of course individually. In 1980, the United States had 50,000 people behind bars for drug law violations, and now there's 500,000. Drug offenses also are the leading cause of arrests in the United States. There were almost 1.2 million arrests in 2020, and the majority of those were for personal possession. So not large scale moving drugs or drug dealing, it was personal possession. Money funneled into the drug enforcement has meant less funding to improve public safety and has left essential education, health, social service, and public safety programs struggling to operate. And so this image, I think it's kind of tiny. I don't know if you can see it, but I'll try to zoom in here so I can read some of these facts, just showing the financial impact. So $293 million worth of equipment transferred from the military to law enforcement through the 1033 program in 2019. $3.5 billion, that's the amount of money taxpayers will spend funding the Drug Enforcement Agency, or I guess that's how much they did spend in 2021. $6,500 was spent, is spent per minute by the Drug Enforcement Agency. And $47 billion is the estimated amount that the US government spends per year enforcing drug prohibition. So obviously that's a lot of money that instead of going to services and education is going to enforcing laws that are not proven to minimize harms or minimize drug use. Next slide, Lindsay. And then, so this is from, I think some of you are probably familiar with the Minnesota Department of Health opioid dashboard. This was taken from that dashboard from the most recent released data, just showing that the drug war creates enormous public health costs by limiting the availability of harm reduction programs that could quell overdose and infectious disease transmission rates. Over the last decade, obviously, opioid deaths specifically have been increasing. In recent years, they've skyrocketed. In Minnesota, they increased by 43% from 2020 to 2021. And next slide, Lindsay. And this is just a graph showing the nationwide rise by gender also. This is from the CDC also. And next slide. And so the next principle is, so harm reduction recognizes that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequities affect both people's vulnerability to and capacity for effectively dealing with drug-related harm. So, it's no secret to anyone, I'm sure, on this call that, as we've seen throughout history, laws that are rooted in racism create the very risks and conditions that those laws allege to reduce or eradicate. And it's just really throughout history. The first image on top shows late 1870s propaganda that was used for the first anti-opium laws targeting Chinese immigrants in the United States. And I think, yeah, they used the term yellow terror. And then the one below shows a racist headline that was written in the early 1900s when we saw our first anti-cocaine laws that were directed specifically at Black men. And then the one on the right shows another racist headline that was written around the time that we started to see our first anti-marijuana laws that targeted Mexican immigrants and Mexican Americans. And the next slide. We also recognize that drug laws are used as weapons against activists, rebels, and minorities to maintain control. Drug laws were created to weaponize activities that, you know, were being carried out by like the hippies and rebels and minority groups. And after Nixon left office, you know, he started the drug war, and then he left office, and one of his top aides actually admitted to this, and he said, you know, we couldn't make it illegal to be either against the war or Black people, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. So, you know, just recognizing that the war on drugs is not rooted in helping people. Next slide, Lindsay. And of course, you know, there's always been stigma, but it wasn't that long ago that stigma was heavily intensified and popularized even more, especially during the Reagan era, when he continued to push the war on drugs. And we saw a lot of campaigns that were based in stigma, like the Just Say No campaign that Nancy Reagan created, and the DARE program, the creator of which said that, quote, casual drug users should be taken out and shot. And then famously the Anti-Drug Abuse Act of 1986, which created the mandatory minimums that still exist today, and blocking expansion of safer use supply programs. Next slide, Lindsay. And so, of course, the intensity of this stigma exacerbates social inequities, and we see more drug arrests among people of color. This is from the Drug Policy Alliance. So as of 2020, 24% of people arrested for personal possession were Black people, despite making up only 13% of the US population. Next slide. And then, of course, increased stigma and the racism that fuels drug policies compound the already existing health and interpersonal harms associated with drugs. When people have limited access to the resources they need to use drugs more safely, there are more harms, there's more injury and more death. This is another graph taken from the most recent opioid dashboard. Before this was released, the data was from 2019, and I think it was showing that American Indian Minnesotans were, I think it was 7 or 8 times more likely to die from drug overdose than white Minnesotans. And the 2021 data shows that they were 10 times more likely. So that disparity has actually increased. And next slide, Lindsay. Thank you. So this principle says that harm reduction understands drug use as a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe use to total abstinence, and acknowledges that some ways of using drugs are clearly safer than others. So there's a lot of writing on here, but I just wanted to kind of list out, there's lots of different reasons that people use drugs. There's a lot of different ways that people use drugs, and there's a lot of different scenarios in which people use drugs. And I think this is often lost in the wider conversations about drugs. We really only see the drug use that causes harm, or the drug use of people who are lacking the resources for privacy and safety. It's really impossible to know just how many people use drugs, and many people with the resources are able to do it safely without being targeted by law enforcement, and with privacy and comfort. So there's medical reasons people use drugs, spiritual, people use drugs for sexual enhancement, just simply for fun, for coping, to fit in, for curiosity. And I think, of course, there are sometimes bad reasons that people use drugs. And I think that there are also scenarios that people are forced into it. There are many different ways people use drugs: orally, intravenously, smoking, inhaling, intramuscularly, and then boofing, which is via the anus. And then the different times that people use drugs. So during fun events, people use daily or not daily, sometimes multiple times a day, at bedtime in the morning, or after traumatic events. And the next slide. And these are just some images that sort of goes without saying, but I like these diagrams. So the one on the left shows that there are many different types of drugs that people choose to use. And then the image on the right just shows sort of the spectrum of safest drug use to most harmful. And it's really like a wide spectrum. And I think at any point in the spectrum, there can be tools used to make it safer. For instance, if people do have to reuse their syringes, there are ways to clean them out. And I think that's not something that a lot of people like to talk about, but it's important to be able to teach people how to do that. And the next slide. And as far as accessing support, it's also complex, and there are so many different ways that people can do that. AA and the 12 steps has obviously become the most popular. Abstinence is seen as the superior approach to wellness when it comes to substance use. But there are so many different other approaches, and upholding an abstinence-based model can, in some instances, be harmful if it's pushed too hard. So we think that it's important to recognize that some people do not have the goal of abstinence, and that some people have different metrics of success than we do. There are just many, many different paths to wellness. So, there's smart recovery, that just as another example, which is a non-abstinence based recovery support community. And then medication first models are great too, because they allow people the very necessary physical ease and comfort to make clearer and more informed decisions for themselves. Next slide, and then I'm going to hand it over to James.
Hello. Our next principle is one I really like to start out with. Affirms people who use drugs themselves as the primary agents of reducing the harm of their drug use, and seeks to empower people who use drugs to share information and support each other in strategies which meet their actual conditions of use. And I like to start this off because as harm reduction is becoming more popular and accepted for the mainstream, the core value of harm reduction started as one drug user trying to help another drug user, one drug user giving another drug user a syringe, and trying to keep that person, whether it's their loved one or family member or friend, alive. And I think that that's something that can sometimes often get lost as harm reduction grows in popularity. And also too, as a person who's used drugs for decades of my life and has history as a drug user, understanding that I know things that just work, and then there was also a lot of things I didn't know because we didn't have the education or the tools that that's more available today. But one of the things that still is real is the fact that drug users are the ones that are doing most of the reversals. We're not out there at 3 in the morning down on Bloomington or under the bridge, and it's like one drug user helping out another person. It just reminded me of a story too of I was coming to work back in like 2019 over by IPTF, and there's a group of women that I knew, and we started talking, and they just talked about like how the importance of the wall was for them because of that community and built the ability to have people around them in order to like make sure that they could stay alive and stay safe. And then when dispersing happened, that seemed to lessen, and people were more about, you know, just trying to like keep watch out for themselves. Yeah, next slide. And this one is, so as I stated earlier, I've history of drug use. I didn't know I was doing harm reduction at the certain time. And again, there's oftentimes I wasn't. I got interested in harm reduction because I learned about drug user organizing, particularly the first group, Vancouver Area Network of Drug Users, VANDU. And I was really blown away by the empowerment, because when you're a drug user, specifically certain drugs, there's so much stigma that you feel like you have no power. And just hearing about like a group of drug users that organized together, but then also mobilized and were integral to start the Insight Clinic, which we'll talk about in a little bit, overdose prevention site in Vancouver, the first one, was really empowering. And then there's Input, which is the International People Who Use Drugs, which is nationally or internationally, and huge support because like there's other countries that are even dealing with a lot worse oppression towards drug users, like not too long ago in the Philippines under Duterte and the genocide that was taking place there with the drug users. But then there's also active groups happening here in the United States. One of them is the Urban Survivors Union. This is San Francisco Drug Users Union. I immediately, when I first heard about drug user organizing, I reached out to somebody named Lee Ertel, and he responded like 2 minutes later, and I ended up joining a group called Morpheus Project, of which where I also met Sue Purchase. Both of those two people, very integral pieces of harm reduction history here in Minnesota. So it's like, it was really nice to be in a town, in a city that actually had some attempts toward that. And I do think that, as we'll get into later, that it's very essential to like some of the recent bills that have passed too. So next slide. And this so it ensures that people who use drugs and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them. And again, I see this as not like making sure that folks who use drugs are actually heard, and not just somebody that's going to volunteer or somebody that's going to do just menial tasks, because that's part of the stigma towards drug use, opposed to like the fact that today there's a lot of very smart people who use drugs, right? And when we stigmatize people in that way, we're like removing their agency, and there's a lot of agency to be happened. In fact, like some of the integral pieces of the recent omnibus bills that passed were like people advocating that we're drug users. This year. Oh yeah, another thing too, like I want to mention also that like kind of like always rubbed me raw. I go to like different harm reduction conferences, particularly here in the Twin Cities, and the people would be presenting would maybe be myself, which again I have history, but I'm not a part of the community that I'm serving. And other than, you know, in our own role, is the fact that like we need to make sure that when we're having these conferences and stuff like that, that we get people at the table so they can speak for themselves, opposed to me speaking for them. And that's kind of a consistent piece of like what I see when I read this principle. So next slide. Okay, calls for non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. SSPs being really important to there. You can see like just how they reduced was it like 50% reduction of like both HIV and HCV with syringe services. Let's see here. One of the things that I was always used to growing like over the last few decades through my drug use was I've been in multiple treatment centers. Some of those treatment centers would be considered, we call them strong arm treatment centers, kind of like Bettina was brought up a little bit, but they were very shameful and shaming as a person. So seeing for me, and that's the only thing I ever knew up until like I learned actually about harm reduction, was there's a very shame-based 12-step program that I can be a part of. And not in that saying all like, and I just want to reiterate that not all AA meetings are like that, but some of the treatment centers I've been to, I did experience that, and that shame alone, like if I was to go out and use, I'm immediately going, it's either all or nothing kind of concept, which harm reduction doesn't, has taught me that there's different ways to navigate that, especially if things are a little rough at the time. But also I want to the picture above is so the left picture is like a syringe service kit that a safe use kit that we hand out to folks. The one on the right is a safer smoking kit, and I want to just mention that a little bit because right now federally we're still unable to buy smoking supplies, and that's something that I know here locally in Minneapolis, but also across the country there's been like a lot of advocacy of trying to change that, because the simple fact is that it helps reduce the dangers of drug use quite a bit, whether it's HIV or HCV or maybe even reduces overdose quite a bit, but also things like endocarditis, which is like kind of been rampant among the people that we serve here in East Phillips neighborhood. Okay, next slide. Yeah, so briefly mentioned the Steve's Law that passed like back in 2014. We're all pretty aware of it. We were handing out naloxone prior to that, and there was like all of the risk. Like we understood that the police didn't know exactly what they were trying to charge it, so people would actually be getting charged with like having a narcotic on them. So that was a really good thing. We're seeing like just the acceptance of naloxone is such a huge piece of harm reduction that unspeakable, but also drug testing. And today we're allowed through our funding to distribute fentanyl testing strips, which obviously over the last 5 years or so, like has increased immensely. So all good things. And next slide. All right, so the next principle establishes quality of individual and community life and well-being, not necessarily cessation of all drug use, as the criteria for successful interventions and policies. So the overdose prevention sites are such an important piece of harm reduction, both globally. So there's currently close to about 200 overdose prevention sites across the world. The first one, again, like mentioned earlier, was up in Vancouver, BC, here in North America. And again, VANDU was like a really integral piece of making sure that got opened. New York City just recently opened, was it last year or whatever, like 2 different sites, both in, was it Harlem and then Washington Heights. And yeah, so like just like super important piece of harm reduction. Yeah, I'm bubbling here. All right, next slide. All right, another piece of harm reduction that's been really integral is like the expansion of methadone and then Suboxone, which we do here at the clinic. One of the things that I've been hearing a lot about lately, and which I do agree with, is like as we're like looking at overdose, like expansion of these things and overdose prevention sites and drug testing or whatever. It's like the reality of it is that we really need to try to look at like what the world look like with a safe supply. The highest causes of overdose deaths are still not knowing what you're getting or how much you're getting. And as we've seen, like just recently with like the contamination of xylazine or tranq within the supply that's out there, both here locally, but all over the country. Overdose deaths are again increasing. It has happened like back over at the wall, like U4770, which is called the pink back then. It's like wiping people out at the wall quite a bit. A lot of overdoses over there due to that. And there's like all these different synthetic compounds that are popping up. And again, we don't like you can have all the naloxone and all the overdose prevention sites in the world, but if we continuously have a dangerous supply, we're continually just allowing this to happen. So there's a lot of us that are hoping like down the road we can see some kind of like vision of like what could the world look like with a more regulated, legalized drug supply opposed to what we're getting today. And then also like who we're supporting in that, which is basically cartels and a number of other like not wonderful organizations. I remember when Canada legalized marijuana up there across the board, the first people that complained were the Hells Angels because they owned the marijuana trade in British Columbia. And so basically they were crying about like what were they going to do now and all this stuff. So yeah, so I like safe supply is something hopefully that will be one day in the future, or even a discussion point, which I don't see it too much at this point. But also there was a group up in Canada, Drug Users Liberation Front, DULF, that actually would order drugs over the darknet, which is maybe might be a surprise to some people. It's actually the safest route of getting drugs. And then like they were able to test them with actual proper testing equipment. And then they would distribute that out in the downtown east side of Vancouver to people so they would have that supply. And I believe they're still doing it. It's very minimal at this point, like what they're able to do. But I do know that like up in Canada, they did, or at least in BC, they have legalized small amounts of drugs, which I think they did in Portland too. All right, next slide. Yeah, so I want to touch on this real quick, and there's probably people that know a little more about this than I do, but it's just like some huge steps with harm reduction just happened here in Minnesota. Previous to that, like the medical marijuana law that was passed a few years ago, I'm a person that has cancer, so I really like that law. I should not be criminalized for using something that's going to help me hopefully stay away from other harder drugs. But then now recently the recreational marijuana law that I always think back at like growing up in the 80s and just how impossible something like that was to imagine. And so good job with Minnesota on that. The syringe services in Minnesota was always one of those gray states in the past where like it was tolerated but not legal. That's changed. Drug paraphernalia, very huge things. A lot of people are getting popped over there just having like a pipe or a foil or whatever on them. And I don't know, maybe somebody else knows too. I haven't looked into it, whether or not like they'll still charge you if there's a substance in that paraphernalia. But either way, it's a big step. Drug testing, as talked about earlier, we're able to hand out fentanyl testing strips. There's now xylazine testing strips, which we're still not, because they have not been FDA approved yet, with certain funding that we use for our syringe products. And again, safe consumption sites. It's oh yeah, and the drug paraphernalia too, just to make a note, like Minnesota is the first state to legalize drug paraphernalia, which is pretty awesome. Drug consumption sites, another wonderful thing that has happened and that we need. I know back when I had more spoons available to like do this work, I was part of like different efforts to try to get some legs under that, and like that always failed. Really wonderful seeing this right now. I know I live here in the East Phillips neighborhood, and there's been neighbors meeting every Tuesday for the last couple years. Like now that's forming again over in East Phillips Park. If you ever want to like know about or go there, I can direct you to that. But they've been like promoting and advocating for an overdose prevention site, particularly in the neighborhood, but then other people from different neighborhoods have been showing up, and they've been also working with local like council members and stuff with that. So really great to see this. And hopefully like it's just like we're the second state to legalize it or make it legal officially, other than Rhode Island. And I know Providence has been fighting for it quite a bit for quite a while. And I think Maine is like on the verge of maybe doing it too. So that's pretty great. So hopefully you can see that down the road. Obviously, this doesn't mean, as we've seen in Rhode Island, doesn't mean it's going to happen. Probably there's going to be a lot of other barriers with that, but it's a stepping stone. Like all this was such an amazing stepping stone as far as harm reduction goes. And I just want to like really quickly talk about the psychedelic task force that was also part of that bill, which basically allows they'll do research into what like the using psychedelics for like different mental health treatments or whatever, PTSD, depression, anxiety, which has been proven to be very effective in the past. As a person who's done a lot of psychedelics in my life, I on my own switched over to using those back in the day as more of a medicinal method. And I found it to be really effective. Also, I would briefly mention ketamine, which I was really gleefully surprised earlier this year when I looked into it for my own PTSD, that not only is it like available in Minnesota, but also like it's covered by health insurance here. At least I know mine is. And that's something again, like that just like wasn't happening like even 3 or 5 years ago. So really great steps that's taking place in Minnesota, and I'm pretty proud of it right now. All right, last slide. Yeah, so just briefly, just like sprint service and outreach at NACC, just want to touch base on what we do here. I joined NACC back in 2018, and I love NACC, like the amount of harm reduction, core harm reduction values in this clinic is like just wonderful and amazing to me. As a person, again, who's, has history, I've had a lot of like not great experiences at different healthcare settings. And as I state on the bottom, compassion and dignity from the staff, not just through the harm reduction team, but all across the board here at the clinic. It's just totally wonderful. And this is just some of the stuff that we do here if you're interested as a harm reduction team clinic. And that's all I got. Thanks.
Well, thank you, James and Tina, for an excellent presentation. Does anybody have any questions? We have about 9 minutes left.
I know.
had
Go ahead, please, Angela.
I had a question. I have some in-laws in Florida, and they said that they now have like a vending machine for naloxone. How do you, or have you heard of that? And like, have you seen like the outcomes, or has anybody heard about that?
Yeah,
Go ahead, Tina.
we've been hearing about it. And there's actually a project right now happening in Minnesota. It's a partnership between UMN Duluth and Johns Hopkins, and they're going to be putting a couple up north. I think Lindsay can remind me where those are going to go. And yeah,
we've been on the Boys Fort reservation.
Yeah. And we've been meeting with, we just started meeting with a professor from Johns Hopkins who does evaluation and was evaluating vending machines. And I guess I don't really know exactly what the outcomes are yet. I think like I love the idea of them as just as a a way that people can access certain supplies, especially naloxone, or even just like tampons or something when services are closed. But then of course there's this question of like, is the money required to fund them worth it, versus the benefits? You know, I don't really know what the like cost benefit analysis really says about that yet, because I think it does require a lot of resources. And what I know is that you have to like build a vending machine specific to the products that you're going to be giving out. And it has to be built like specific to the size and shape of the items that you're going to be handing out. And so it's like, I have questions about like the longevity of something like that, and the sustainability. But yeah, Michelle, Dr. Robbie, Lindsay, I'm not sure if you remember
Yeah.
Yeah.
the
So
outcomes.
one of the things, so one of the things that he had mentioned is like, yeah, the vending machines are cool. But also you kind of want to look at what products are you trying to get out there? So if you're trying to get just naloxone and tampons, just put out a basket, right? Just put out a basket of those items, because there's no need to really monitor or control those items. Whereas if you're doing syringes or other safe for use supplies or things that you're wanting to monitor, then you do kind of that vending machine, and there's tracking and there's grants, and yes. So I guess the big point, I think that the big answer is yes, vending machines are a thing. And we've been in some conversations about, is it a good idea? How do we do that? Where would we put them? What do we do with the, cold weather? What do we put in them? But my initial thought is, yeah, let's put vending machines all over the place.
Yeah, I think that there's just some complicated discussions around it. So like, for example, one of the things they said is that like, if you have your clinic, if it's only going to be there available during clinic hours because it's too cold to put outside, then why would you not just give people the supplies in the clinic hours? And I think that, and then there's a question of the stigma. You want something that people can, some people are just not comfortable coming and asking for things. So then we actually talked about what other spaces might be good for vending machines, perhaps, like the light rail station, or perhaps like we talked about the library, for example. So there's just a lot of like, and so he had some good insight into like sort of the, how do you measure the effectiveness of a vending machine, and whether it's just a cool idea that you want to do, but really you already have effective mechanisms in place to distribute the things. So I guess what we're trying to say is it's kind of complicated, and we're exploring it.
Yeah, it's a really cool idea.
I would like to, so a few years back, what we, us and Southside decided to put up little Narcan stations all over East Phillips. And we would move them around in peak areas, and we would go through them, but like there's sometimes like neighbors didn't want them there, so they're taking it down too, right? Like, but there was still like just not enough available. Like people would be like, we just don't have enough. There was like, people overdosing at 3:30 in the morning, and there's nothing, we couldn't find any naloxone. So I think like, yeah, it's really complicated. I know up in Vancouver, I always like when I go up, my partner, like ex-partner now, lives up in Vancouver, and I always would go up there and stop at the downtown east side, that Bandu office, and chat with those folks. And I know up there they actually had a smoking vending machine. But again, I was like imagining it in my head, like outside, and then I brought it up and they laughed at me, and they're that thing would be there like 10 minutes. Somebody be dragging it down the street, but like I don't see that with as much of the naloxone, because it would be nice to have like more available than like what we were even putting up. But and then also if it could be mobile, because I think at least like what we're dealing with is people moving around quite a bit as they're getting dispersed. So like last year it was over by my place. Now this year it's really quiet over there, and everybody's over by the light rail, or over here, over by Taco Bell or something like that. So that like I love the idea, but yeah, I do think that there's probably some kinks to work out and make it like a reality.
I just imagine like a vending machine on wheels, kind of like a video game or something.
And that's what I was thinking, because we have a few different nations in the area, in the Tucson urban city area, and we put on a lot of events. So I could see something being mobile. It's like, oh, we're having a world variety event going on. Let's take it over here. Oh, we're gonna be on whatever res. Let's take it over there.
Yeah.
So like kind of putting it off to the side of the main event, and people can go as like discreetly, you know, and I mean still hand it out. But like some of you were saying, it's like the Indian Center can be open and we offer it, but there's some people that have that shame or whatever, and they don't want to ask for it and put a face to who's receiving it. So if we had it off to the side and made it mobile and move it around at wherever you go, I think that's a better idea than just a permanent vending machine and leaving it outside in the Arizona heat or in the winters, you know.
Yeah, we're back to the ice cream truck.
Yeah.
Oh my gosh. See, all right, we just need a van. Oh my God. Okay.
Always comes back to that. We just need a van. Yeah, thank you for the question.
Thank you.
Any other questions? I have about a minute left.
I just wanted to say, Tina, you said a couple times at the beginning that, you know, you thought this would be like maybe, you know, a little too information that we all had in hand already. And I thought it was a very different perspective than what we usually, the conversations we usually have about harm reduction. And it was really great to have it presented in the format of from both you and James that sort of centered it where it was born. Yeah.
Great. Well, thank you for that.
Now I feel like I learned a lot and great images in your
Awesome.
presentation.
Great job, James.
I bumbled my way through.
All right, well, thank you, Tina and James, and thank you everyone for joining us. Next ECHO will be June 21st, and that's with Linda Black Elk talking about traditional medicines. So please join us again.
Oh, it'll be a good one.
Yeah.
Thank you.
Thanks, everybody.
Bye.